In this video, I'd like to explain the ST segment changes we see on our ECGs in ST elevation myocardial infarctions and non-ST elevation myocardial infarctions. So firstly, the key to understanding this is to realize that it is the baseline of our ECG, which shifts following infarction, not the ST segment itself. So firstly, in STEMIs. Now STEMIs are transmural infarcts. They result from occlusion of a coronary artery, which causes the myocardium supplied distally to the occlusion to become ischemic and subsequently infarct. Now this is what you would typically think of when you hear AMI. Once the myocardium has infarcted, it begins to undergo coagulative necrosis, and the tissue cannot maintain its resting membrane potential of negative 90 millivolts. Under the hypoxic conditions, ATP is not generated and there is no fuel for the sodium-potassium pumps to work, so they stop and the membrane becomes more permeable. There is ion leakage and ultimately the membrane potential becomes more positive. This can be thought of as partial depolarization, and it moves in a direction away from the area of infarction. When we do an ECG, we place leads around the chest, and the leads will record the movement of current in a specific plane. So for instance, I put an electrode of a lead here, and it will record current that travels towards it or away from it. To measure the baseline, the electrode records any movement of current prior to the spontaneous depolarization of the SA node. Normally, this will be 0, and we'll see an isoelectric baseline. So this would be normal. This is a true baseline. But if an infarction has occurred, due to this basal level of depolarization, what we see is a net vector traveling away from the electrode. When a positive vector travels away from the electrode, this results in negative deflection. So when we're recording our baseline, because we have this basal level depolarization away from the electrode, this results in negative deflection of our baseline. In other words, our baseline shifts downwards. So, P wave, QRS complex, everything seems normal until we get to the ST segment. It will be elevated. The reason for this is that after the QRS complex and before the T wave, the ventricles are completely depolarized. So I'm drawing pluses here to reflect the positive membrane potential of the cardiomyocytes. Normally, this would be read as a voltage of 0 because there is no difference in voltage across the myocardium. If the baseline was at true 0, we would see the ST segment return to the isoelectric line. But because our baseline has abnormally been shifted downwards, the ST segment, which reflects a true voltage of 0, appears elevated. Infarctions are of tissue distal to whatever coronary artery has been occluded. So by determining which leads show ST elevation, we are able to localize the aspect of the heart in which the infarct has occurred and then link that to the coronary artery supplying the area. So by looking at our 12-lead ECG, seeing which leads are showing ST elevation, we are able to deduce which coronary artery is affected and then tell the cath lab to thrombolyze accordingly. It's a similar story for NSTEMIs. But instead of the infarct being transmural, we have a subendocardial infarct. The infarct in NSTEMIs most often results from an acute imbalance between myocardial oxygen demand and blood supply, and is the subendocardial tissue that infarcts first, as it is most distal to the coronary arteries. It is important to note that similar ECG changes occur in NSTEMIs and unstable angina, and the way we differentiate between the two is by testing for our cardiac biomarkers, e.g. troponin and CKMB. These biomarkers will be elevated if the tissue has infarcted, as in the case of an NSTEMI. But if the tissue has only undergone ischemia, we will not see biomarkers, and we can therefore assume it is unstable angina. So now to explain ST depression in NSTEMIs. So once again, it's to do with the baseline. Now here I'm drawing the true baseline. Because this is infarcted tissue here, it is depolarizing for the same reasons I have mentioned. And the depolarization travels in our direction away from the infarcted tissue. If we put our electrode in the same place, we can see that this basal level of depolarization is traveling towards the electrode. So we have a vector, a positive vector, traveling towards the electrode. This will result in positive deflection. So when we're recording our baseline, it is shifted upwards. So we have an upwards shift of baseline. P wave, QRS complex, everything seems normal until we get to the ST segment. As I mentioned before, between the QRS complex and the T wave, the myocardium is completely depolarized. So we would expect the electrode to show a reading of 0 volts, and this would be reflected by the ST segment being on the isoelectric line. But because the baseline has abnormally been shifted upwards, the ST segment, reflecting a voltage of 0, appears depressed. One more thing to add. The ST changes are acute and will disappear over time. The reason for this is the infarcted tissue is undergoing a process of coagulative necrosis, which will eventually end in fibrosis. Fibrotic tissue does not have the ionic leakage which we saw in infarcted tissue. So there is no baseline shift. As such, the ST segment returns to normal. Hopefully this video was helpful in explaining the ST changes. Hopefully you're able to understand it. If you notice any mistakes, feel free to point them out in the comments. Cheers.